this word? Thoracic scapular joints sliding around, or my scapula's got to work. Now my appendages have to get involved. Strategies, ankle, knee, hip, elbow, wrist, shoulder, strategies that complement that triplanar blockage. And it kind of starts in the way that we just described it. The first thing you lose is what? The ability to flex your thorax and acquire a good zone of apposition, followed and accompanied by the ability to side bend in a frontal plane, followed by the limitations of rotation that then you compensate with and develop in order to be able to turn to the right and to the left. So that poor guy has a bigger problem than breathing. He thinks he's fine. He feels fine. Until he's shown that you're not fine, he would never change. He would go to a doctor that would say, hey, take my scalenes off because I don't know what else you can do. You're right. I don't know if I can change. And he's married to a physical therapy assistant who can never get him better. This is years ago. This is my Sanese days. Another Sanese day picture, Christy. Compensatory strategy now of axial structures. Mike, you're right. Look at the side bending of that right side. And they'll develop a thoracic rotational. We have a 4-day course every year, advanced integration course, to talk about integrating abdominals. 4 days on integrating abdominals. With all these different patterns that you see in a human that can produce different curves of a spine. And this particular curve is a real common curve, right thoracic curvature. In other words, the convexity is to the right, the concavity is to the left. This is a person's strategy, developing strategy has resulted in a curvature of the spine with the thorax going to the right and a lumbar thoracic curve going to the left. Mike, let's do what you just did again. What was the first thing she probably lost? The ability to exhale. That's sagittal plane. What's the second thing she just lost? The ability to expand which chest wall? The right side. That's frontal plane. What's the third thing she lost? The ability to rotate her axial structure with ribs, because the ribs now can't shift and rotate on each other. And then you have a result of a person standing on the right side with their right shoulder lower than the left, and she was told by her mom, can you imagine mom? We all have them. Aren't they beautiful people saying this? Stand up straight. And the more she stood up straight, the more she developed that compensatory curve. If she did stand up straight, she would just be in a position like the former picture. She'd be like that. See the right shoulder, how forward it is? But her mom said to do what, everybody? Pull it back. And when she pulled it back, she developed a rib hump. She had to create some place for the shoulder blade to sit. So these are compensatory things. On page 3, these people that with these brachial issues and these thoracic issues also have complementary shallow breathing. And it's usually shallow breathing limited to one side. They have limited diaphragmatic function, often on the left. Their diaphragm's ability to contract and draw in air is limited on that left side. And I think that this is the point we need to make right here. Gail, when I take a breath of air in with my left diaphragm, I need to side bend to the left, trunk needs to rotate to the right, and I need most of my fulcrum underneath my left central tendon. That would be the floor. I need the floor under my central tendon. And when this diaphragm contracts, air that's being pulled in by it is going to be moved through the bronchial tree more on the right side than the left, because of the position I'm in when I took that breath in. That's normal. So the left diaphragm leaflet is responsible for more airflow into your right lungs, and the right diaphragm leaflet is more responsible for air into the left lungs. Does that make sense to everybody at this point? So every time I breathe, and even if I'm not coordinated with my breathing gait, which you should not have to be, you will be able to breathe better when you are coordinated when that activity is going on. I could be in discoordinated activity, and I could be on my right leg, and I could be turned to the right, and I could still breathe with my left diaphragm. Air's still going to go on my right side, but the primary respiratory diaphragm is now on which side? The right side, because that's where neurologically I'm centered. And we will want to center ourselves when we're short of breath on the side that's going to give us more capability of breathing comfortably. So which side would that put me on more than not? The right side. So we usually find people coming in with shallow breathing, limited in diaphragmatic function on their left side. Case in point, you could send a person home with nothing but a left stance kind of program and have them sing at church, recite poetry, talk out loud to get their voice projected while they're on which side? And you wouldn't have to worry about that doggone balloon. If, this is the big if, the right chest wall can what? Expand. That's tomorrow. How do you get a right chest wall to expand? Because if that chest wall, Rick, has been going for years without expansion, somebody's got to help that neurological, soft tissue process that's been going on for years to actually take place now while you are standing on the left side. So decreased mobility of the upper chest wall on the right is the next bullet. We got to make sure that you do everything right to begin with, but if you don't have the ability to actually function when you're doing it right, then the function itself is going to be what? Compensatory. You're going to figure out another strategy. So doesn't it make sense for all of us to take another point home? I want to do everything I can in my life with my loved ones to keep which chest wall expanding? The right. Just, I want to do it. It's inherent. Anything I do, I want to keep this chest wall what? Open on the right side. You saw the lady and the man that was doing the carpentry work. But the shingling work. Shoulders usually don't drop on the left side. When I see a shoulder drop on the left side, I'm thinking other things. Trauma, surgery, neuromuscular disease, loose connective tissue disorder, visual dysfunction, visual patterning, etc., foot issues, shallow acetabulums. My brain is going, Stephanie, what is going on for that type of a person to be walking around this earth looking like right-sided, left shoulder is down? Dental, joint, neck, something's going on that's not allowing that normal triplanar function. But when I see people walking in with this pattern on the right side, I pretty much expect that. You're normal. In fact, welcome. You came out. Thank you for admitting it. Okay. You're comfortable here. You're safe inside this building. We know who you are. You're one of them. You cannot get your right chest to expand. You're accepted here. We understand why. And they're going, oh, thank God somebody does. Because my trainer doesn't, my PT doesn't, my doc thinks it's all in my head. You know, I'm not pulling anybody's chains right now. They're not welcomed. They don't even know if they see it. My husband's been telling me for years I don't stand straight. I think I stand just fine. But now I gotta admit he was right. I probably am not. So it's really nice to be able to educate somebody. The biggest problem you've got is not the leg you can't stand on, not the body God gave you. The biggest problem you have is you don't understand and feel that you're having a limit in getting air on which side. You don't even know what air on the right side feels like. If I put a Zerk in you right now and start that air compressor up, you would feel like, whoa. And that's what we kind of do in this course. We're going to get the right chest wall, Chad, to what? Open up. And they're going to go, whoa, wow. Can I just stand here a little bit? I got to get reacclaimed. I got to own the floor differently. My forefoot and rear foot and my hips and my back is like, oh my goodness. That's different. And I know I'm making this fun, but I'm telling you, it's a reality check. This is a vestibular process, ventilatory vestibular activity. How can vestibular processes ever take place without ventilatory activity complementing it? Yes.
In my clinical thinking up to this point, then, if I have somebody in that posture where their right shoulder is down, and what I might find clinically is that they have a left downslipped innominate, making their leg long. In absence of trauma.
I love what you just did. Making their leg feel what? Long. Very common scenario right there. You lay them on their back and their left leg may even look what? Long. She called it a what? Say it again.
Left downslip.
Thank you. But the reality is, that whether it's a downslip or not, the reality, you're in a position that put that leg in a longer state. Keep going.
So, which came first, the chicken or the egg then? In trauma, the football player running down the field and somebody gets a hold of his left leg
Yep.
and it gets pulled down,
Yep.
that's obvious. But
Yep.
in somebody without trauma,
Yep. Their trauma is a little different. First of all, let's take the football player.
did this come first or did the...
Well, it didn't come first. It didn't come first. It's just this way. Linda, I'm just trying to tell you. It didn't come first. It came. Do you follow me? The sun is going to come up in the east. It will go down the west. Otherwise, we're on a different planet. You came with it. It didn't come first. You have it. It's there. It's normal. Now, what came first? How you compensated for it. It's there. See, Linda, the only difference between that question and my answer is, I could tell you it possibly came first, but that would be an inaccurate lie. It didn't come first. It was there. It's always been there. It came first the minute you stopped shifting and doing it on the other side.
So these people who do not respond, they keep coming in with...
Thank you.
Then you have to go at it.
You have to go at it from a perspective, they can't do something on the other side. What is it they can't do on the other side? Unload. They can't unload the right side. Their brain won't let them unload the right side. Their ventilatory system won't let them unload the right side. Their neurosensory system won't let them unload the right side. Their organs won't let, and their autonomics and their vagal, and It didn't come first. It's there. They have human on their forehead. It came first the minute they stopped moving with ribs that allowed them to do what with their body weight? Shift. The football injury player is easy to understand. It was an upslip on one side, a downslip on one side. It was the way they coughed when they got maybe untied their shoe and threw out a disc. It was maybe the work they had day in and day out repetitively. The tractor driver. Do you follow me? All those things make sense to everybody. The reality is, all those things I just talked about was what came first on a pattern they weren't keeping alternating. Does that make sense? That's what came first, and that's not accurate. It's there. You never were first. You are asymmetrical. That's a great question. Do you understand the importance of that question? Now, Rick, how many people really will ever fully believe that? Well, someday. But the evidence is stinkingly overwhelming. Overwhelming evidence that it's there. In different perspectives, different fields. Most of my background didn't come from journals that I get professionally.